Hello, good evening.
Madam, we are live now. Shall we start?
Okay. Yeah. Okay. Yeah.
Aditi, Madam, first let us share our screen. Then you can start. Aditi,
Yes, sir, I'm sharing the screen. Ma'am, wait for
okay.
me.
Okay. So, good evening, Doctor. Aishman on behalf of Shield Healthcare, welcoming you all in today's session on PPIUCD, complication of PPIUCD and its management. So, it's my honor to introduce Madam. Although Madam doesn't need any introduction, just it's our responsibility to introduce her. Madam is the ex-associate professor from Pulo Chana Medical College in Dunka, Dhambat. So, with this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, for your valuable time on this platform, Shield Connect, and over to you, Madam, for further questions. Thank you very much.
Ma'am, now you can share your presentation.
Hello, good evening. Today I have to talk about the PPIUCD, which is most advanced government-run program. Am I audible?
Yes, Madam.
This is PPIUCD is the most advanced government-run program, family planning program. So it is being applied in every hospital, and we have to evaluate the merit and demerit of this PPIUCD so that in future it should get popularity and more acceptance. So we have to know about the basic things of the. So what is contraception? Contraception is the intentional prevention of pregnancy by artificial or natural means. Now, what is family planning? Family planning allows individual and couples to anticipate and attain their desired number of children and the spacing and timing of their births. It is achieved through use of contraceptive methods and the treatment of involuntary infertility. Now, what is unmet need for family planning? An unmet need for family planning is the number of women that wants to stop or delay childbearing but are not using any method of contraception to prevent pregnancy, including also pregnant women whose pregnancies were unwanted or mistimed at the time of conception, and postpartum amenorrheic women who are not using family planning and whose last birth was unwanted and mistimed. Now, the key facts about the contraception. Among the 1.9 billion women of reproductive age group, that is 15 to 49 worldwide in 2019, 1.1 billion have a need for family planning. Of these, 842 millions are using contraceptive methods and 270 millions have an unmet need for contraception. Contraception is required because use of contraception prevents pregnancy-related health risk for women, especially for adolescent girls. Only one contraceptive method, condoms, can prevent both pregnancy and transmission of sexually transmitted infection, including HIV. Use of contraception advances the human right of people to determine the number and spacing of their children. Contraception offers a range of potential non-health benefits that encompass expanded education opportunities and empowerment of women, sustainable population growth, and economic development for the countries. 55% of country's population living in 24 states, union territories, and union territories has already achieved replacement level of fertility. The total unmet need for family planning is 12.9%. Unmet need for spacing is about 5.7%, and unmet need for limiting children is 7.2%. Various types of contraceptions are being used, that is condom 5.6%, contraceptive pills are 4.1%, IUCD and PPIUCD is 1.5%, male sterilization is 0.3%, and female sterilization is 3 to 6%. Now there are various contraceptive methods that is present in the basket of the National Family Planning Program. That is temporary method and permanent method. The temporary methods are condom, conventional contraceptive, popularly known as Nirod. Then oral contraceptive pills, that is combined oral contraceptive pills. Mala N is being provided by the government. Setcroman. Setcroman is a non-hormonal contraception that is selective estrogen receptor modulator, popularly known as Chaya or Saheli. It is weekly used. Then another one is emergency contraceptive pills, that is also known as easy pills. It is high dose estrogen pills, so it should be avoided. IUCD is intrauterine contraceptive device. It is a device which is inserted inside the uterus to prevent the pregnancy. It is 380A and 375, copper 380A and copper 375. Injectable contraception is medroxyprogesterone acetate. It prevents the ovulation, so there is no question of fertilization. Now, permanent method is male sterilization, that is the conventional vasectomy and non-suturing vasectomy. Now, the female sterilization is mini-lap and laparoscopic tube ligation. Both this male and female sterilization is the permanent method. The IUCD can be intrauterine contraceptive device is inserted inside the uterus, and it is inserted at various time intervals. So interval IUCD can be provided in all public health facilities by trained provider in outpatient department also. The PPIUCD or postpartum IUCD inserted within the 48 hours after delivery in facilities conducting deliveries. Then post-abortion IUCD inserted immediately or within 12 days of abortion. Worldwide, over 100 million women have used the intrauterine contraceptive device. However, in North America, less than 1% of women use this highly effective method of contraception. Postpartum period. Now the postpartum period is again divided into three parts: immediate postpartum, early postpartum, and extended postpartum. The immediate postpartum is post-placental and within 48 hours after delivery or childbirth. The immediate postpartum period is an ideal time to educate and counsel a woman on exclusive breastfeeding as a contraceptive method. Counseling on future fertility, birth spacing, or limiting intentions, and provision of appropriate family planning method like IUCD, sterilization should be provided in this period. Early postpartum, up to 7 days postpartum sterilization can be performed within this time period. Messages on lactational amenorrhea method should be reinforced. Extended postpartum, 6 weeks to 1 year spacing method, 1 year after childbirth. A spacing method like IUCD and other methods as per the medical eligibility criteria can be provided. Laparoscopic mini-lap tube ligation can also be performed during this period. Now the policy. The copper T380A is approved for immediate postpartum insertion as a method of contraception. The PPIUCD must only be placed after the woman is counseled and gives informed consent. Counseling should take place in the antenatal period, in early labor, or immediately postpartum. The PPIUCD can be placed immediately following delivery of the placenta during cesarean section or within the 48 hours following childbirth. The IUCD must be inserted only by the service provider according to national standards. PPIUCD insertion must be done in the healthcare facilities that provides delivery services and has acceptable standards of infection prevention. Immediate postpartum, postplacental. The IUCD insertion within 10 minutes after expulsion of placenta following a vaginal delivery in the same delivery table. Intercaesarean insertion that takes place during the caesarean delivery after removal of placenta and before closure of the uterine incision. Within 48 hours after delivery. Insertion within 48 hours. Insertion within 48 hours of delivery and prior to discharge from the postpartum ward. Post-abortion, insertion following an abortion if there is no infection, bleeding, or any other contraindication. Extended postpartum and interval. Insertion any time after 6 weeks of postpartum. Manual insertion of PPIUCD. Manual insertion of PPIUCD are generally done in cesarean section and sometimes after vaginal delivery also. Hold the IUCD between the index and middle finger of the hand. Pass it through the uterine incision and place it at the uterine fundus. Slowly withdraw the hand, ensuring that the IUCD remains properly placed. And if the cervix is closed, dilate it very gently. Close the uterine incision, taking special care not to incorporate the IUCD strings into the suture. Assisted by ring forceps. After removal of placenta and membrane, uterine cavity is explored with the sterile gauze. Copper T380A is introduced through the uterine incision with the help of Kelly's forceps or long sponge holding forceps. Marina string may need to be trimmed prior to the placement. It was placed high at the fundus using non-touch technique. If the cervix is closed, dilate it very gently. Strings were folded upward, pointing towards the fundus to avoid the inclusion into the suture, and it minimizes any chances of spontaneous expulsion. Now you can close the uterus. There are two types of IUCD available. There are two types of IUCD available in India. Copper-bearing IUCD made of a small inert plastic frame covered with copper sleeves and/or copper wire. Progestin-releasing IUCD, which continuously release a small amount of levonorgestrel. Among the copper-bearing IUCD, the copper T380A is available in the government program, and it is used for immediate postpartum insertion. Copper 375, popular commercial name is Mini Multi-Load, has been approved for use in the private sector with the planned introduction into the government program. Mode of action. The intrauterine contraceptive device interferes with the ability of sperm to survive and to ascend the fallopian tubes where fertilization occurs. It alters or inhibits sperm migration, ovum transport, and fertilization. It stimulates a sterile foreign body reaction in the endometrium potentiated by copper, that is aseptic endometritis, which recovers usually soon. The PPIUCD acceptance is increasing day by day. In India, its acceptance is 16.3%, maximum in Tamil Nadu and West Bengal. In Tamil Nadu, it is 40.2%, whereas in West Bengal, it is 37.8%. And minimum is in the Mizoram, that is 1.2%. Intrauterine devices are a highly effective method of reversible contraception. Limitations of IUCD in postpartum period. The specific limitation of an IUCD placed in the immediate postpartum period include increased risk of spontaneous expulsion. The skilled clinician with the right technique of insertion are associated with lower expulsion rates. Perforation of uterus while placing a PPIUCD immediately after delivery of placenta or during cesarean section or during first 48 hours postpartum is unlikely because of the thickness of the uterine wall in the postpartum period. No such cases are reported in the literature. The other limitations are usually very short time interval for counseling, and otherwise it is same as the interval IUCD. The World Health Organization has developed a list of absolute and relative contraindications. Absolute contraindications are pregnancy, pelvic inflammatory disease, puerperal sepsis, immediate post-septic abortion, severely distorted uterine cavity, unexplained vaginal bleeding, cervical or endometrial cancer, malignant trophoblastic disease, copper allergy, and breast cancer. Relative contraindications are risk factor for sexually transmitted disease or human immunovirus in HIV positive women, impaired response to infection, in women undergoing corticosteroid therapy from 48 hours to 4 weeks postpartum, and ovarian cancer. The side effects are bleeding, pain or dysmenorrhea, hormonal and functional ovarian cyst. Bleeding. Irregular menstrual bleeding is an increase in amount of bleeding are the most common side effects in the first month after insertion. Menstrual blood loss in user of copper IUD increases by up to 65%. The average number of days of spotting or bleeding appears to decrease over time. Users of copper IUCD have an average of 13 days of bleeding or spotting in the first month after insertion, decreasing to an average of 6 days at 12 months after insertion. Use of non-steroidal anti-inflammatory agent or tranexamic acid may help to decrease the amount of menstrual blood loss. If bleeding is persistently heavy and prolonged or associated with clinical or laboratory signs consistent with the severe anemia, offer iron replacement therapy and consider removal with the patient's consent. Pain or dysmenorrhea. Pain may be physiological response to the presence of device. It works as a foreign body. But the possibility of infection, malposition of the device, including perforation and pregnancy, should be excluded. Postpartum use of levonorgestrel intrauterine device has been associated with decrease in menstrual pain. Management. Management depends on the severity of pain. Determine the severity of symptoms. How severe is pain? How long has pain lasted? When did pain start? Is pain accompanied by other symptoms like bleeding or fever? How well is the woman tolerating the pain? Perform an appropriate assessment to rule out pregnancy and infection. If symptoms and physical findings are mild and consistent with the postpartum uterine involution, reassure the patient. Recommend a short course of anti-inflammatory before and during menstruation to help reduce the menstrual pain and cramping, which is bothersome to the client. If cramping or pain is severe, remove the IUCD. The levonorgestrel uterine device appears to exert some systemic hormonal effect, even though the daily dose of levonorgestrel is extremely low. Hormonal side effects includes depression, acne, headache, and breast tenderness. Functional ovarian tumor, ovarian cyst. Functional ovarian cyst has been reported in up to 30% of levonorgestrel intrauterine users. Since these cysts usually resolve spontaneously, they should be managed conservatively. Risks are uterine perforation, infection, expulsion, and failure. The uterine perforation is negligible. It is still not reported. Uterine perforation is rare complication of intrauterine device insertion, occurring at a rate of 0.6 to 1.6 per 1,000 insertions. All uterine perforation, either partial or complete, occur or are initiated at the time of intrauterine insertion. Infection. Evidence from large cohort studies, case control studies, and randomized controlled trials indicate that any risk of genital tract infection after the first month of intrauterine device use is small. There appears to be an inverse relation between the risk of infection and time since intrauterine device insertion. The Women's Health Study data showed a relative risk of PID of 3.8% in the first month after insertion, reaching baseline risk after 4 months. Investigation by the World Health Organization found the risk to be highest in the first 20 days following insertion. Although insertion of intrauterine device contaminates the endometrial cavity with bacteria, the cavity becomes sterile soon afterwards. Exposure to sexually transmitted infection and not the use of intrauterine device itself is responsible for PID occurring after the first month of use. Management. Perform an appropriate assessment to include vital signs, abdominal pain, pelvic examination, and appropriate laboratory studies like pregnancy test, complete blood picture, culture, to rule out other problems like endometritis, appendicitis, partial intrauterine device expulsion, uterine perforation, pregnancy, ectopic pregnancy, and urinary tract infection. Rule out PID and endometritis if suspected. Begin treatment immediately with an appropriate antibiotic regime as per national guideline or local protocol to reproductive tract infection and sexually transmitted infection. Remove the IUCD if symptom persists more than 72 hours. If the woman does not want to keep the IUCD during treatment, remove the IUCD 2 or 3 days after antibiotic treatment has begun. When sexually transmitted infection is suspected, history of high-risk behavior, counsel the women regarding condom use for the protection against future sexually transmitted infection and recommend treatment for the partner. Most of the immediate PPIUCD insertion related complication can be prevented by careful screening of the client, strict adherence to correct infection prevention techniques, and meticulous attention to standard insertion technique. Problems at the time of insertion. Client discomfort or pain possible Sign symptoms. A moderate amount of discomfort or pain associated with intrauterine placement of IUCD is common during the insertion regardless of timing after delivery or technique. Management. Reassure the patient for the moderate amount of discomfort is associated with the insertion and continue communicating with the patient during the procedure. Perform the procedure as gently and as quickly as possible. Displacement of IUCD, possible signs, symptoms. IUCD can be visualized in the cervix or upper vagina after placement. The woman has discomfort or pain. Length of string visible in the vagina is not consistent with the fundal positioning in an immediate postpartum uterus. Management using the Kelly's forceps or sterile forceps, remove the IUCD and reinsert the same IUCD if not contaminated with all aseptic precaution. If the IUCD has been contaminated, discard it and use a new IUCD. Complication and management. Cervical laceration, excessive vaginal bleeding. After vaginal delivery, sometimes cervical laceration is found. Management. If laceration is seen, repair as needed depending on the size of laceration and amount of bleeding. Uterine perforation. Uterine perforation. There were no reported cases of uterine perforation while placing the PPIUCD in any of the studies reviewed. However, if it occurs, the basic steps for managing a uterine perforation are the same as that of regular IUCD insertion. Sign and symptoms. Sudden loss of resistance to the inserting instrument during insertion. Unexplained pain. Uterine depth greater than the expected. Management. If suspected during insertion, stop the procedure immediately and gently remove the instrument and IUCD. Keep the patient at rest, start an IV drip, and observe the vital sign and abdominal tenderness, guarding, or rigidity. If there is severe abdominal pain, any change in the vital sign and peritoneal sign appears, refer for emergency surgical intervention. Prophylactic antibiotic can be given, repair as needed, depending on the size of laceration and amount of bleeding. So key message of this IUCD is that it is safe, convenient, and cost-effective, reversible, long-term birth spacing method. It can be applied in the outdoor, on the delivery table, in the postpartum, before discharge from the postpartum ward. So it is conveniently applied. Should be a part of maternal, newborn, reproductive health package. Janni Suraksha Yojana is an opportunity to add PPIUCD into family planning program and could address the high unmet need for family planning in India. It is all about making the right choice at the right time. Responsible us for a responsible future. Thank you.
Thank you very much, madam, for this nice presentation. As we understand that family planning is a big issue, and for that PPIUCD is a need of the hour. So thank you very much, madam, for your valuable time. Just give me 1 minute time to check if any question is there, ma'am. Madam, I could find one question. So if you allow, I can give it to you. Hello, ma'am. Am I audible?
Yes, sir, you are audible, sir.
Madam, am I audible?
Yes.
Yes, ma'am. The first question is during the PPIUCD insertion, what strict
Yeah,
norms should
Mr.
be
Suman
followed
sir,
to?
you are audible. Please ask the.
Yes, I was
Yes.
asking the question. Yes, ma'am. During the PPIUCD insertion, what are the norms should be followed to reduce the chances of infection?
So it should be done whenever after delivery, after delivery of placenta, just mop the vagina, and the PPIUCD copper T 380A is itself in a flap which is sterile. So it should be introduced or inserted by the trained personnel only, who are trained at the national level. So they should take all the aseptic precaution, and that should be as much as no touch technique. So hold the IUCD with the Kelly's forceps, which is sterilized, and gently put your left hand on the abdomen, elevate the uterus, and gently apply through the cervical canal. It should be as much as possible no touch technique.
Thank you very much, ma'am. And ma'am, another question is if it is found that this IUCD has been displaced, so what is the immediate precaution should be taken here?
Since it is PPIUCD, it is visible in the vagina or in the cervical canal. The string comes out. So remove it, and if it is contaminated, discard it and take another IUCD to apply as soon as possible. And if it is delayed, suppose the patient is coming after 15 days or 16 days, then remove it and give her one course of antibiotic and all that, and tranexamic acid and all that, and then again call for her reapplication.
Thank you very much, ma'am. And another thing, ma'am, cervical laceration is a big issue in case of this insertion during this.
Right.
So
Actually,
if excessive,
we are going after vaginal delivery. So sometimes there is cervical laceration. So
yes,
better you resuture, either we will see for the site of bleeding. If it is cervical tear, then repair the cervical tear. If it is vaginal tear, then repair the vaginal tear. And you have got 48 hours of time. So pack the vagina with sterile gauze or betadine packing, and again re-examine after 2 or 3 hours. If there is no bleeding, then you can apply within 48 hours.
thank you very much, ma'am.
If the laceration is very bad, then don't apply it.
Thank you, madam. So, ma'am, I could not find any other question. So, if you allow me, then we can conclude this session.
Okay.
So, thank you very much, ma'am, for discussing this very important topic and for addressing the queries. So, in future also.
Burning topic. It is just now. It is a burning topic.
Yes, ma'am. Yes, ma'am. Rightly agreed, ma'am. So, thank you very much once again, ma'am, for your valuable time in our platform and discussing this burning topic, as you mentioned. So, in future also, I will look forward to conduct some medical session with you to some other aspects also. So, thank you very much, ma'am. Once again, on Shield Connect. So, have a good day, ma'am. Thank you very much.
Yeah, madam, thank you very much. And thank you for the audience. Thank you, Sumanda. Thank you, Bharat sir. And thank you, Aditi. Thank you.
Thank you all.